Good evening, and welcome to the board meeting of the Washington Township Hospital Board of Directors. This meeting is called to order. If you'd stand, join me in the pledge. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
We welcome Christine Flores with us tonight. Christine, if you'd take the roll, please.
Sure. Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Eben.
Present.
Thank you, Christine. We'll move right away now to our educational session and have Nancy, if you'd introduce that, follow it through. Going to hear tonight from Nancy herself.
I'm going to start this evening's education session, and I will be followed by Chris Henry, our Associate Administrator and Chief Financial Officer, and Donald Pipkin, who has been with Washington Hospital since 2006 and is our Assistant Chief of Strategic Management. Tonight, the objective is to develop a common understanding of the problem every hospital in the country faces in the wake of the Affordable Care Act. For those who follow the monthly reports of our hospital's financial performance, it should be crystal clear that in a comparatively short period of time, a high-performing hospital has experienced a significant reversal. Understanding the budget for the fiscal year 2014-2015 that will be presented to the Board of Directors in open session that is scheduled for Wednesday, June 25th, requires some definition and discussion of the changes in the healthcare industry that have brought us to this juncture. Tonight, we're going to talk about a problem that has been 50 years in the making. It's a problem that not only affects our hospital, it affects ultimately every man, woman, and child in the country. It is a problem that knows no political party, even though it is a bone of contention between Republicans and Democrats. In 1966, we initiated a comprehensive health care program for senior citizens, underfunded at its inception. This has changed the face of financing of health care throughout the nation. At no time has the federal government paid the full cost of care for its beneficiaries in Medicare or in Medicaid. This practice has led to arcane reimbursements practices that defy logic and are largely inexplicable, much less understandable by the average citizen, who is the self-same citizen who contributes tax dollars to fund these programs, however inadequately. The financing of healthcare in the United States is fraught with problems, many of which have become part of a very public national discussion, a discussion that involves a massive amount of finger-pointing and levying of blame. Unfortunately, the blame game, as it is being practiced today, never seems to lead to a common public understanding of the core issue, the underfunding of the Medicare Trust Fund. Yes, there is significant value in looking at overutilization, fraud and abuse, and quality metrics. These are all important issues that need and require our attention. However, when we discuss these matters to the exclusion of the core issue, a seriously underfunded Medicare Trust Fund, which is facing unprecedented enrollment, we do a disservice to all of us. For the sake of argument, suppose for a minute that we could eradicate all fraud and abuse, control overutilization, and address each and every deficit in quality. Suspend reality for just a moment. The heart of the problem would still be there. Without increasing the amount of money to pay for the increased enrollment alone, the trust fund will go broke. We have this slide, which is one of my favorites, because what it expresses is the population of employed citizens whose taxes will support the plan are fewer in number as each year goes by and the baby boomers begin to retire. So an already underfunded program is approaching disaster. The finger pointing is a distraction. It's a scattergun approach to fending off reality. It has resulted in scapegoating that generates headlines. None of these things will change the ultimate reality. Taking a page from the industry that I've worked in all my life, you can't treat a disease if you haven't made a proper diagnosis. Every year since 2003, the government has been required to issue a report on the status of the Social Security and Medicare programs. The 2013 report states, the Hospital Insurance Fund again fails the test of short-range financial adequacy, as its trust fund ratio is already below 100% and is expected to decline continuously until reserve depletion in 2026. That's not very far from now. Most of us will still be here in 2026. Neither Medicare or Social Security can sustain the projected long-run programs in full under the currently scheduled financing. And that's a conclusion of the report. The report urges lawmakers to take action sooner rather than later so that the public has time to prepare. The trustees of the Medicare Trust Fund project that the Medicare Hospital Insurance Trust Fund will face depletion in 2026, as I mentioned before. That's just 12 years from now. Since 2008, this trust fund has paid out more in hospital benefits and other expenditures than it receives in income in all the years under reserve and until reserve depletion. The report includes the observation that the Affordable Care Act will reduce growth in costs by more than was previously projected by lowering Medicare Advantage program costs. But something that should be understood by all of us, whether we're a beneficiary or a provider, the current law precludes payment of any benefits beyond the amount that can be financed by the trust funds. It is a matter of law. The Medicare Modernization Act of 2003 requires the Board of Trustees of these programs to determine each year whether the annual difference between program cost and dedicated revenues exceeds 45% of the total Medicare cost in any of the first 7 fiscal years of the 75-year projection period referred to in the law. 2 consecutive years will trigger something called a Medicare funding warning. The warning directs the president to submit proposed legislation within 15 days of the next budget submission to respond to the warning and requires Congress to consider the proposal on an expedited basis. To date, after 7 of these, elected officials have not enacted legislation responding to these funding warnings, which have been included in all prior reports. Nothing's happened. Nobody in Washington is following the law. This year's report shows the difference between cost and dedicated financing revenues to exceed 45% of total Medicare costs during 2013. And that, as I've mentioned, did trigger another Medicare funding warning. 7 consecutive years. The Hospital Insurance Trust Fund does not meet the short-range test of financial adequacy. The inevitable question arises when examining the impact of the Affordable Care Act. Affordable for who? The regulations promulgated by Health and Human Services and the Center for Medicaid Services in the wake of the Affordable Care Act all point to a plan to reduce healthcare spending through introduction of price transparency and price sensitivity. Given last year's experience at our own hospital, it's evident that this is a successful strategy. It will get them part of the way there. And we have experienced a significant drop in patient care activity, for which we have been paid a great deal less. High deductible, high copay insurance plans do discourage members of our community from seeking care once they are aware of the financial outlay they must make before they can utilize their insurance plan. Many people purchase these plans enjoying the reduced premiums, not realizing what is required of them in the way of copays and deductibles when they need to use their insurance. The impact of the insurance exchange is still something we're evaluating. However, it's abundantly clear that the absolute increase in the number of people enrolled in Medi-Cal, which does not remotely come anywhere near paying for the cost of care, is increasing the losses at this hospital and all the others. And it could not be more apparent that we still have millions of people in California who are uninsured, making the achievement of universal coverage as illusory as ever. The words "kicking the can down the road" have become an often repeated criticism of our lawmakers in Washington. Failure to own up to the looming crisis year after year puts all of us at risk. According to the U.S. Census Bureau, the nation's 65 and older population is projected to reach 83.7 million in the year 2050. This is our nation's toughest financial problem. And I don't believe it can be solved by asking wealthy seniors to contribute a little more, as has been suggested by the president. The Treasury Department is aiming to slice approximately $700 billion from Medicare over a 10-year period that we're partway into, mainly through cost controls for providers. Patricia Newman, who's the director of the program on Medicare policy at the Henry J. Kaiser Family Foundation, has offered the following opinion of this. The good news doesn't mitigate the long-term challenge with the growing elderly population. That's a direct quote. So in order to understand where we're going, we have to have a common understanding of where we've been and where we are today. So I've asked Don Pipkin and Chris Henry to take some of that on this evening. Who's first? Don. Okay.
Thank you, Nancy, and good evening. So I'd like to start this evening by discussing with you the environment in which healthcare providers are currently operating. So I thought we'd do that by looking at the national environment and then looking at the state environment and some of the responses that healthcare providers have had and the impact of those responses. And then I'll hand this over to Chris to discuss how these figures impact Washington Hospital. So probably the most visible component of the national healthcare environment is the Affordable Care Act. And we've seen certain components of the Affordable Care Act implemented. The individual mandate that requires individuals to have health insurance. Insurance exchanges, both the federal-run exchanges and the state exchanges. We've seen 7.1 million people enrolled through the exchanges as of April. However, there's still an estimated 30 million Americans who are uninsured. We've seen insurance coverage for dependents is extended to age 26. We've seen insurers no longer able to deny coverage based on pre-existing conditions. We've seen the electronic health record mandate, and we've seen increased access to Medicaid for citizens under 65 with family incomes up to 133% of the federal poverty level. However, many components of the Affordable Care Act remain a moving target. We've seen the large employer penalty delayed to 2015. We've seen SHOP, or the Small Business Health Options, which provides small businesses access to the federal health insurance exchange, delayed. We've seen the individual mandate deadline delayed till March 31st of this year. The employer mandate was delayed for small businesses with 50 to 99 employees, was delayed until 2016, and employers with more than 100 employees will be phased in after that. We've seen a 2-year extension for for plans that are not compliant with the Affordable Care Act extended into 2017. And as required by the Affordable Care Act, Health and Human Services has yet to define a single standard definition of essential health benefits, and instead has allowed each state to pick a plan as a benchmark to assign essential health care benefits for that state. What we have not seen delayed is federal payment reform for hospitals. We continue to see increasing downward pressure on reimbursements, as the federal government essentially asks us to do more with less and even to do less with less. Now, much of this is driven by what Nancy just spoke about, and that's the sustainability of Medicare. The Hospital Insurance Trust Fund is projected to deplete by 2026. They'll pay out more in hospital benefits every year than income it receives until depletion. Meanwhile, 10,000 Americans are joining the ranks of Medicare every day. And the bottom line is simply that Medicare is not sustainable under the current benefit or financing structures. And politicians in Congress are well aware of some of the legislative mechanisms that they have available to them to solve this problem, such as increasing the Medicare payroll tax would increase the funds and increase the longevity of Medicare. Means testing for Medicare would help to increase longevity for Medicare. And increasing the age of eligibility from 65 to 68 would have a significant impact on the longevity of Medicare. Unfortunately, there simply is not the political will in Washington to pull these legislative levers. So as a result, we've seen CMS implement payment reforms. We've seen the disproportionate share allowance reduction, which Chris will speak to in more detail in a little while. We've seen the 2 midnight rule, and this policy, which was delayed by 6 months with the sustainable growth rate patch passed in April, would require that Medicare inpatient stays less than 2 midnights be treated as and billed as outpatient services. We've seen RAC audits. Now, earlier this year, CMS temporarily suspended the Recovery Audit Contractor, or RAC, program. There is concern that the perverse financial incentives that the auditors have, RAC audits were intended to identify improper Medicare payments to providers. However, the concern relates to the fact that the contracted auditors are paid a percentage of what they are able to collect through the RAC audits. And based on this incentive structure that incentivizes claims denials, the RAC auditors may have been overly aggressive with the monies they were taking away from providers. The financial impact to Washington Hospital from RAC audits from fiscal year 09 to the present is estimated as approximately a takeback of $14 million. Other payment reforms that we've seen: readmission penalties, Medicare Advantage payment reductions, value-based purchasing, bundled payment pilots, and Chris will speak to some of these here in a minute. Also in the national environment, there remains great economic uncertainty. We're still recovering from the Great Recession. Just last month, we finally recovered the 8.7 million jobs lost during the Great Recession, which is good news. However, the recovery has been agonizingly slow. We would have needed an additional 7 million jobs to keep up with population growth. So we're still in the midst of recovery from the Great Recession. There's additional regulations and financing mechanisms that have been delayed. With the sustainable growth rate patch that was passed in April, also known as the Doc Fix bill, we saw the 24% scheduled reduction in Medicare payments to physicians delayed by 1 year. We also saw ICD-10, the hospital coding system intended to replace the current ICD-9 coding system, which had been required to be implemented this year, delayed by at least until October 1st, 2015. Meanwhile, providers had been moving ahead and implementing ICD-10 and spending considerable resources to do so. It's as though, given all the uncertainty still facing healthcare providers, it's as though we are being asked to build the airplane as we taxi down the runway. And even with that, there's the uncertainty of the November elections and the impact that will have to the Affordable Care Act and to healthcare regulations. In the California environment, California hospitals provide care to 46 million outpatients and 3.5 million inpatients every year. From 2001 to 2010, the number of hospitals in California declined by 5%, while the number of licensed beds declined by 3%, while at the same time the population increased 8%. The number of skilled nursing beds in hospitals declined by 1/3. Use of emergency departments increased 12% during that same time period. While at the same time, staffing per bed rose 14% across the state, due in large part to changes in California nurse staffing laws. Salaries, wages, and benefits accounted across the state for half of hospital operating expenses in 2010, having increased 100% since 2001. Uncompensated care, the combination of charity care and bad debt, rose 50% to $2.4 billion across the state, and from 2001 to 2010, charity care nearly doubled. Also in California, we've seen the implementation of Covered California, the state-run health insurance exchange. 1.4 million people signed up for insurance through the exchange, and when you add the numbers for Medi-Cal, that number exceeds 3 million people. However, there still remains 3 million uninsured people in California. And as Nancy had mentioned, the newly enrolled Medi-Cal individuals are likely to face access issues, as increasingly physicians are not willing to accept new Medi-Cal patients due to the fact that reimbursements simply do not begin to cover the cost of care. We're also seeing a large number of high-deductible, high copay plans being offered through the exchanges, and policyholders are largely unaware of their benefits and the cost of them in actually receiving medical care. We're seeing declining Medi-Cal reimbursement rates. We're seeing employers continue to shift healthcare expenses to their employees. And commercial payers, following the lead of CMS, are exploring new payment models with increasing downward pressure on reimbursements. We're seeing accountable care organizations, pricing transparency, narrow and very narrow defined networks, and at-risk contracting. And the result of this is that many independent hospitals are experiencing financial challenges. So faced with the downward pressure on reimbursements and declining inpatient volumes, hospitals across California have been forced to respond. Some have responded by affiliating, some have responded by merging, and some have responded in the only way that they could. Now, this is just a sampling of headlines from layoffs in primarily Northern California in the last 18 months. These represent about 1,000 positions. But this is certainly happening all across the country. Some hospitals have had no choice but to close. Doctors Medical Center in San Pablo is facing imminent closure in just a couple of weeks. San Leandro Hospital faced significant financial hardships. Alameda Hospital faced significant financial hardships. So it's happening here in the Bay Area. Experts predict that over the next 5 to 10 years, up to 40 hospitals will close in the state of California. That's 10% of the hospitals currently in this state. And the impact, in addition to the healthcare impacts, there's significant economic impacts to those closures, to the communities that those hospitals serve. About 18 months ago, we presented a report here from Economic Planning Systems that provided an analysis of the economic impact that Washington Hospital has on the district. In 2011, this hospital had an economic impact of nearly $700 million on the district and over $800 million on Alameda County. In 2011, Washington supported over 3,300 jobs in the district and over 4,200 jobs in Alameda County. So these closures have not just a significant healthcare impact, they have a significant economic impact as well. And with that, I'll hand the presentation over to Chris.
Okay, so it's clear that Medicare can't pay the bill, that Medicare is employing a number of mechanisms to reduce what they have to pay out for the bill. And what I'm going to try to do tonight is bring together a lot of the things that we've talked about individually, which individually some seem like not so much, some seem like a lot. But when you put them all together, the magnitude of this is actually even surprised me when we actually put it all together. And I'm going to start with not a new reality, but actually an old reality, and Nancy alluded to this, and we've looked at these numbers before. Really, from its inception, Medicare has not paid the cost that we have to pay to provide the care to their beneficiaries. In 2013, Medicare paid us on the order of $86 million less than our cost to provide care to Medicare beneficiaries. What this has resulted in is a financing system that is really composed of cost shifting. Hospitals have to recover this differential, and the way they've recovered it over the years is by through their negotiations with private insurance payers. They recover that cost in the rates they receive from those private insurance companies, who then recover their cost from their premium payers. So really what we have in essence here is a hidden tax that appears in the premiums paid by employers and individuals when they go to buy insurance. Again, the bottom line is Medicare is broke. As Don mentioned, they're employing a number of mechanisms to reduce that payment. And while the stated goals of these programs really are admirable, a lot of them are quality related, the real goal here is to reduce payment, and they are doing that very effectively. First of these programs that I want to discuss, and we've discussed before, is the value-based purchasing adjustment. And what this is it's a CMS initiative, and actually these initiatives are both initiatives that have arisen from the Affordable Care Act and from CMS outside of the Affordable Care Act. So you're going to see both of these as we go through this. This is a Medicare initiative that's intended to provide incentive payments based on quality of care provided. It's determined by scoring on a set of 3 different types of measures. The first is process measures. That includes things such as a lot of these things you see Stephanie Williams on report right here in our board meetings. Things around heart attacks, door to cath lab in 90 minutes, administration of aspirin upon arrival in the ED, cardiovascular discharge instructions and the ratios around that provided to patients when they're discharged. We've seen the quality measures around antibiotic use, also catheter-related infections. All of these things are metrics that are reported to CMS that they then take and grade against the rest of the population of hospitals and make a determination on whether we qualify for an increased payment or we have a deduction. It's very difficult to qualify for an increased payment. Another one of the measures they use is patient satisfaction measures, and this is based on the percent of patients who always say they have a favorable experience in specific areas. Now, any of us who work with the public in general know that it's very difficult to get 100% of your patients to say they've had a favorable experience in all their encounters with a particular business. Another one of the measures they use for qualifying for this is mortality rates related to discharge of patients with heart attacks, heart failure, and pneumonia. Again, very difficult things to control, particularly when a patient is leaving the hospital and leaving our sphere of care and not taking their medications, not actually complying with the discharge instructions given to them. So, again, we took a run at what we estimate are the impact of the value-based purchasing adjustment has been on us, and we projected it through the end of 2015. And the cumulative impact on our net revenue from the value-based purchasing initiative, we estimate to be just a little bit under $500,000. Next thing I want to talk about is the hospital readmission adjustment. This is an adjustment established by the Affordable Care Act. This reduces, again, payments with higher admission rates within 30 days of discharge for Medicare patients with specific conditions. These include acute myocardial infarction, and I'm proud I was able to say that, heart failure and pneumonia for 2014. In 2015, we're adding 3 new ones. We're adding chronic obstructive pulmonary disease, which is a very difficult condition to control. Also, total hip and knee arthroplasty. Again, we took a look at what we project the total impact of hospital readmission adjustments might be through the end of fiscal year 2015, and we estimate that number to be a little bit less than $1.2 million in reductions in our Medicare reimbursement as a result of this initiative. Coding recapture adjustment. You've heard me speak for a number of years of the behavioral adjustment. This is CMS's determination, and again, this is outside of the ACA. This has been going on for a number of years. We've been talking about it for quite a while in our budget presentations. CMS has determined essentially that hospitals have learned to code too efficiently, or as they like to phrase it, that we code too aggressively, and therefore there are coding errors resulting in CMS paying too much for care. And as a result, they make decisions on how much they're going to reduce payment in future years to account for that. You can see the impacts of this down at the bottom. In the numbers you see is an $8 million recovery from coding in 2008 and 2009 that the government has decided they're going to recover over 4 years. The rest of the numbers you see there are permanent reductions in payments as a result of the coding reduction. Our estimate at the end of 2015 is that the coding recapture adjustment will have reduced Washington Hospital's net revenue by a cumulative $17.2 million over 5 years. Disproportionate share. So, disproportionate share was implemented in 1995, and it was really the federal government's recognition that they were in fact not covering the total cost of care, particularly for Medicare beneficiaries with disabilities and low-income patients that come to the hospital. DISH is a fairly complicated calculation, and we've talked about the SSI ratio before and changes in that, and that is the ratio of Medicare disabled patient days to total Medicare days, and also included in that factor is the percentage of Medi-Cal days that make up our total patient days, to come up with an additional payment to try to make up for that cost we're incurring to take care of low-income folks. That number has been cranked down on over the last few years through adjustments in these calculations, and we'll see those numbers in a second, but effective in fiscal year 2014, actually October 1st of 2013, the ACA required a 75% reduction in DISH payments. Now, of that 75% reduction, a percentage was put into a pool to cover the cost of uncompensated care, but it does not recover the total amount of DISH reduction. And here are the numbers. So in fiscal years 11, 12, and 13, we saw changes in the actual calculation of DISH with the ratios I talked about a bit. And those amounted to quite a bit of money, $1.7 million in 2011, $1.8 million in 2012, and over $3 million in 2013. In 2014, we're estimating that the net impact of the ACA required reductions to be about $3.4 million, and in 2015, another $4.6 million. So the net cumulative effect of this over the 5 years, we're estimating our net revenue be reduced by about $14.8 million. Sequestration. We're all familiar that when the federal government couldn't get a budget, sequestration cuts took effect. For hospitals, that was 2% of their Medicare payments. Over the 3 years since sequestration took effect, and estimated out into 2015, we're estimating about $4.7 million in net revenue reduction as a result of sequestration. Let's not forget HMOs and PPOs. The environment has created an environment with HMOs and PPOs where they have become very aggressive in negotiations. They understand that the additional cuts to Medicare payment are going to exacerbate the shortfalls of payment to cost, and that hospitals would be desirous of recovering those costs, again, through the cost-shifting mechanism. They're saying no. They don't want to play cost-shifting anymore. They're coming in to our negotiations with, in fact, the last couple of negotiations we've had have started with contract cancellations and demands for significant reductions in payment. Over the last 5 years, the largest ones that we've experienced are Blue Cross and InHealth. We're aware of our contract cancellation with Aetna, which had a fairly significant impact on our net revenue, but they've also shifted payments away, so we have some offsets on the expense side. But the bottom line is we're losing money in our negotiations with HMOs and PPOs. And the cumulative effect of that through 2015 is estimated to be $35.8 million in net revenue. So we bring this all together, and you can see the challenge that we're having. The estimated reductions in net revenue as a result of all this for 2015 are about $26.7 million. The cumulative effect of all this over 5 years is estimated to be a little bit over $74 million in net revenue. And here's the result. Up through 2011, we were keeping pace pretty well with our increases in expenses. Inflation has continued through all of this. Increases in wage and benefit costs, as well as the supplies we have to purchase from our various suppliers. Until 2011, when things really started to crank down, we've done pretty well. But you see the sudden drop. We did have a bump up in 2013 that was largely volume driven, but in 2015, we don't see that volume coming back. We had a significant drop this year. We've seen it all year. And the result is the lines are on the wrong side of each other. We really need that red line to be on top of the blue line. And as a result, we're going to have to work hard to get it there. So.
In today's Wall Street Journal, there was an article from the Associate Dean of the Carlson School of Management and the Director of the Medical Industry Leadership Institute at the University of Minnesota. His name is Stephen Parenti. And he was talking about the post-mortem of Obamacare, or the short, unhappy life. And he made some predictions about Obamacare, beginning with he doesn't think it will survive past 2020, and he gave reasons. The consumers who saw spikes in their health premiums last year are going to experience the same trauma this year, but the steepest price increases won't occur until 2017, after three things happen. First will be the Affordable Care Act's essential benefits requirements. All plans, including those currently exempted for hardship and old plans extended for various reasons, must provide all of the law's mandated benefits from January 1st, 2017 forward. On average, roughly 15% of the plans offered in 2013 will not qualify for sale on the insurance exchanges once all the extensions have been completed. Depending on the state, as many as 60% of plans sold in 2013 will not be permitted to be sold in 2017. The law's reinsurance program will also expire in 2017. Health insurers will no longer be able to bill the government for 80% of a patient's health care costs when they make more than $45,000 in annual claims. This is a special allowance that our tax dollars are paying the insurers. The multi-billion-dollar risk corridors for insurance companies will sunset in 2017, ending the taxpayer bailouts that kick in when insurance companies providing ACA plans lose money. So even though the insurance companies are coming here and pounding us into dirt to get lower rates, they have a bailout that's provided by tax dollars through the federal government. Employer-sponsored coverage will also come under pressure. The data show that an increasing number of businesses are likely to cancel their plans in favor of letting employees get coverage on the exchanges. His research indicates that over 5 million will lose their employer-based insurance by the end of the decade. And this is consistent with an estimate that was made by the Congressional Budget Office that says the ACA will lead to a 7 million person decline in insurance provided by employers by 2020. They're also predicting Medicaid enrollment will increase by 2 to 3% annually through 2024. They're also predicting that by 2024, there will be more than 40 million uninsured, roughly 10% more than today. So this is the environment. And in this new world order, we're going to bring forward a budget document for the board's consideration on June 25th. Hospitals all over the country are in the midst of massive and very disruptive change. Moody's predicts that not-for-profit hospitals' expenses will continue to grow faster than their revenues, stating that U.S. hospitals are facing their gloomiest economic outlook in 20 years. One of the major risks identified by Moody's is the transition to a new reimbursement method. That we're going to have to proceed with the renovation of our charge master is driven by these reimbursement changes. The charge master we have today is a product of a soon-to-be bygone era in hospital reimbursement, one that was driven by competition in an era of managed care contracting. The sheer magnitude of the changes that lie before us should leave no one in a state of complacency. There are industry experts that predict that by 2020, 1/3 of the hospitals in the United States will be closed. I don't know what those numbers are based on, but we already know of hospitals teetering on the brink of closure here in the San Francisco Bay Area. The 2014-15 fiscal year budget will be one that provides for scaling down our operations to match volumes of patients. Throughout the entirety of the soon-to-be-passed fiscal year, it was not just that our revenues were down, our patient care activity was also significantly below expectations. We must adapt to our new realities, and therefore we have to commit ourselves wholeheartedly to making the most out of the resources that we do have. This means that we'll be learning the techniques of the Toyota production management systems and bring lean techniques to our healthcare systems, with the intent of embedding lean as part of the everyday management of this hospital for the foreseeable future. Lean, as it has been implemented at Virginia Mason Hospital in Seattle, Washington, and in many other institutions, including at UCSF, our partner, is an intrinsically patient-first activity, congruent with the mission and vision of this hospital. This is going to require the cooperation of all of us, every last one of us, from the frontline employees to each and every board member. I anticipate beginning the educational processes as soon as possible. The budget that will be presented to the Board of Directors is one that has been devised with the best possible information available at this time. I will caution all of this. This is an election year, and we will have to deal with post-election uncertainties. quite a few of the more unpopular decisions yet to be made by the federal government regarding Medicare and the Affordable Care Act are being deferred until after the election. This means that depending on decisions made, we may be discussing budget amendments with the board in November and December of this year. We just don't know what's coming next with any degree of certainty. So with that, the three of us are available for questions.
Thank you, Nancy and Chris. We appreciate that information, as gloomy as it is, as difficult it is to handle. I'd like just now, if we could hear maybe a little bit from our physicians. Dr. Nicholson?
I think we're in a very challenging era in medicine where we clearly have the imperative to, as Don Pipkin said, to do more with less. Hopefully we'll not have to do less with less. Maybe we can do better with less. But I think the real challenge out of the years ahead is going to be to really learn how to take care of patients more efficiently, more effectively, and have better outcomes. And that will include, I think, teaching patients how to help take care of themselves. I think there's a lot to be done in empowering patients to be able to monitor and understand and control the various conditions that they have. Things are gloomy now, but I think overall, long term, that this will result in a change for the better, in that we can actually change the way in which we deliver health care, restructure it in such a fashion that overall health can be improved long term.
How has it affected your private practice?
I'd rather not talk about that. It's been challenging. The change in the policies that are there, the high deductible policies, have made it more difficult for patients who have chronic conditions to come in and get seen and to get their routine tests for monitoring and control of their various conditions, which do put them at risk for adverse events in the future, such as diabetes and hypertension, cholesterol issues. So that has been a challenge. So I'm not sure where that is going to go. I'm sure that we're going to see more of these high deductible plans. And one potential benefit out of the high deductible plans may be to provide a forcing function to change the way in which healthcare is delivered by physicians, in that instead of there being the insurance company as the intermediary between what the physician does and what the patient or the payer actually pays, there will be a more direct relationship. And I think overall that will be a good thing. I think we've seen in our society this disintermediation, where you get rid of the middleman and you connect the provider with the purchaser. You connect the physician with the patient much more closely and effectively. And I think we have a lot to learn as far as how we do that well, how we use technology and various types of interaction to do that more effectively. I think that will actually drive some of the improvement in healthcare. But I think there's a lot of pain that we'll see before we see the benefit on the other side of this hill we have to climb.
Dr. Lenny, do you have a feel for the overall feeling and attitude of the physicians on staff as regards to their financial stability, their ability to provide care, their feelings about their own profession?
One thing that's become clear clearly over the last 5 years, if not the last 10 years, the composition of the medical staff has changed from less solo practitioners to more physicians that are part of larger groups as a way of forming economies of scale and more integrated care of the patients. And I think in the past, physicians really haven't been that involved with utilization review, but clearly in the future, I think physicians will have to own that part of taking care of both hospitalized patients and outpatients as well.
Any other questions for Nancy or
One of
for?
the things we didn't talk about was something that Dr. Lunny just touched upon, and that is the impact on physicians in private practice. And 20, 30 years ago, that was the predominant mode. Even when you saw people in practice in the same physical space, they had office practice sharing agreements and were not incorporated in a group practice. And this is a huge sea change for the physicians. And one of the things that is of immediate concern is what happens to people in private practice who don't have the bankroll to fund them with false starts with ICD-10, to put in electronic health records. And when you don't have one next year, there are going to be penalties for that. A big institution like Washington could afford to purchase an electronic health record. I'm not so sure with all the vagaries in reimbursement that the average doctor in private practice can afford all of that overhead. So one of the consequences of this is driving physicians who may have practiced a little bit longer into retirement and young physicians coming out of training programs to look for an employer and not take on the risks of private practice. So how physicians practice is going to change significantly. And that's not something that's talked about a lot. It used to be you graduated and finished your training programs, you move into town and hang up a shingle. It's not going to be that simple anymore. And I think that what will come with all of this is a significant scarcity of physicians. I think that patient access to physicians is going to be significantly reduced, and people will be seeing PAs, nurse practitioners, and other therapists before they ever get to see the doctor. Today, you can make an appointment at the doctor's office and you know you're going to see Dr. Lunny or Dr. Nicholson or Dr. Eapen. That's not going to be the case as this thing begins to progress over time.
That's been a change we've seen in our medical staff as well as the growing number of what we call allied health professionals, which are nurse practitioners and physician assistants on the medical staff.
And we've talked to our lobbyists in Washington, D.C. About some of the impacts that the change in the law and the activities of CMS, and how they've created problems. What we get back from them is that the legislature, the Congress, is not in the least bit concerned about hospitals closing, and in fact see that as a positive outcome.
We have a long, strong history at this hospital, and we commit to the district that we will do what we need to do
I
to
think-
provide care.
We need to stay focused on why we're here.
That's right.
And that is to take care of the residents of the district. And, a lot of the other things that we used to do, we might not do anymore. We're going to have to get down to business and make sure that we can assure that part. And some of our other things that we did that were beneficial for the community but not essential may be set aside. And it's until something significant happens with all of this, I think that's going to very much be, as Bill mentioned, doing less with less. And I think that's reality for all the hospitals. And the thing that nobody's calculated is, you know, what happens when the other hospitals around us who are more financially frail than we are begin to close. And those folks have no place to go. Utilization and access will become a nightmare, and the emergency room will be, you know, the first to experience the adverse consequences of insufficient numbers of hospital beds, because if people won't go away. They aren't going to just stay home. They're really sick, they'll come. And it's going to be a problem because there won't be enough beds.
Well, nature abhors a vacuum. And I think you will have an opportunity. Hopefully our institution will be able to meet that opportunity, but you'll have an opportunity where you'll have many patients who are not insured or underinsured or have high deductible and have to pay out of pocket for their for the care and procedures that they may require. And I would imagine that there will be plenty of entrepreneurs, innovators that will try to meet this challenge. Fortunately, we live in the Silicon Valley, which has got a long history of technological advance and meeting society's needs. And hopefully that will happen here in not only just in electronics and information technology and biotechnology, but also in healthcare delivery. I hope that we can be a part of that revolutionary change in our delivery system, which I think will have to happen.
I think that a lot of the plans for what's going to happen are banking on the idea that somehow socially we're going to re-engineer the American family and that we'll have multiple generations all living under one roof. One of the problems with that is they don't all live in the same town today. And mom isn't staying at home to provide nursing care and housekeeping. Mom is at work because today it takes two incomes to meet the family budget and to pay for a house and for cars and tuition. There are more and more families where the two-family income is an absolute requirement. So I'm not quite sure who's going to be at home to take care of grandma. It's, you know, it's a real conundrum.
Are there any other questions or comments from the board on this subject? Then we'll move on to we'll move on to a consideration of the minutes from May 14, 19, 27, and 28 of this year. Do I have a motion on that?
Move for approval as presented.
A second.
I have a motion and a second. Any comment on that? Christine, if you'll take a roll call vote.
Sure. Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Danielson,
Aye.
Director Epen.
Aye.
Thank you, Christine. That motion passes. We'll now move to our communications. I see no indication that we have oral communications this evening. We'll move then to our written communications and have a presentation from Dr. Lenny.
So our medical staff credential action items from May 2014, we had 4 new appointments. Christopher Carpenter, physician neonatologist. Jacqueline Cayetano, PA. Julie Depper, PA. And Gavin Henderson, MD, neonatologist. For reappointments, we have Dr. Ario Barson, plastic surgery. Dr. Rona Brooks, pediatrics. Dr. Fulton Chen, physical medicine rehabilitation. Dr. Yasser El Sayed, OBGYN. PA Kelly Hawes, Dr. Jan Hensdorf, orthopedic surgery, Keith Jeffrey, PA, Lei Jiang, PA as well, Dr. Savita Krishnan, OBGYN, Dr. Pradeep Kumar, cardiology, Dr. Nancy Mark, anesthesiology, Dr. Eric Okamoto, plastic surgery, Dr. Graham Rodwell, nephrology, Dr. John Romano, plastic surgery, Dr. Barry Rose, orthopedic surgery, Dr. Alexander Saw, orthopedic surgery, Dr. Rita Wadwani, pediatrics, ambulatory status, and Dr. Christina Wong, OBGYN. For conditional reappointments, we have Dr. Zulfikar Ali for a 1-year conditional reappointment, and Dr. Jenny Moltani, neurosurgery, for a 1-year reappointment. Non-reappointment deemed to have resigned, we have Dr. Stephanie Cleese, pediatrician. And formal resignations, we have Dr. Jennifer Lai, internal medicine, Dr. Rajender Narla, emergency medicine, and Dr. Kutancheri Rema, family medicine.
So moved. Second.
Motion and a second. Any discussion on that? My only comment on that is on that list there were 4 PAs. I think a year or 2 years ago that number would have been 0.
I would agree that,
Yeah.
as I stated earlier.
These are good people doing good jobs, but it is a change of procedures. All in favor? I'm sorry, Christine. We need to take a roll call vote on that.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
That motion passes. Thank you. We've had a heavy discussion here tonight on very, very discouraging and yet other subjects. I'm happy to change to something more exciting and absolutely more positive. Gail Tomita will present our service leave report.
Early on this year, Washington Hospital took over the operation of the special care nursery. At that time, it was discovered that several items needed to be provided. The ladies of the quilting group took on several of the projects, and I brought some of the examples. They make quilts that are used to cover the babies in the special care nursery, and I just wanted to share with you some of these quilts. They're actually works of art. I wish I could bring more of them, but they're not just simple quilts. They're really like works of art. They provide this for the babies, and then they're given to the babies when they go home. So it's actually a gift also to them. At the early on at the volunteer conference in Sacramento, the volunteers found that other hospitals in their special care nursery provide what they call a kimono. It's actually a custom-made garment, and it's like this. And what it helps in the special care nursery is that nurses can access babies that have IVs they brought this back, showed it to the nurses in the special care nursery who loved it. So the woman in the quilting group went ahead and made these garments for them. It's been well received. The nurses love it. So it's something else that we've done. Early on in the newsletter, I asked volunteers who knit and crochet to knit and crochet blankets and hats to give to the babies in the special care nursery. The response was tremendous. So much so that we've been able to also offer these items. They knit or crochet these blankets and little hats. And we've been able to also offer it in the birthing center. On Mother's Day, the mothers who were in the birthing center were given as a gift one of these crocheted or knitted blankets. And again, they were well received. So we're really thankful to all the volunteers who do all this work. In the volunteer office, we have these large albums that were lovingly put together by volunteers that kind of give the history of the Service League and Washington Hospital. These are getting old. They're falling apart. So we've decided that we needed to preserve this history. So we had these albums professionally scanned. Now they are on a disc. Also on our I gave Nancy a disc. And they're also on our X drive on our computer. And it's something that we have been wanting to do for several years. We finally were able to do it, and we really have to thank our anonymous donor who made it possible for us to do. It's something that, I mean, history is something that we really need to keep. So I think that's it.
Thank you very much, Gail. I can't tell you what a nice thing it is to hear positive, good, uplifting, and even heart-touching kinds of things. Those are beautiful blankets.
I wish I could bring more of them because they are really, truly works of art. I mean, these ladies just love doing it, and people in the special care nursery, the mothers are just thrilled when they see these blankets and are able to take them home. So it's really something nice. I think the nurses enjoy it also. It's not just a hospital blanket that goes home with the babies.
Again, thank you very much.
Okay.
Be sure that whenever your work that you're doing with the volunteers, that you express our thanks
Right.
to the board of
I
directors.
will.
That's a wonderful, wonderful thing that we can
I
provide.
think it gives them pleasure to hear, like some of the mothers have had expressed, really appreciation for some of these items, and so the ladies just really like doing it.
Again, thank you. Now I'd like to have our medical staff report from Dr. Lunny.
Okay, as of May 30th, our medical staff had 502 members total, 310 active staff, 79 provisional, 21 courtesy, 4 consulting, 1 administrative, and 21 allied health. We currently have 40 applications in process, 23 in the pre-application stage, and 17 with formal applications. And we have 1 physician currently with temporary privileges who was taking care of a pediatric patient with some eye issues, and we didn't have a pediatric ophthalmologist and staff. So,
Thank you. Thank you. Nancy, if you could present our hospital calendar. Start first of all with the video presentation.
Past health promotions and outreach events. On May 20th, best-selling author and speaker Marcus Engel presented to the physicians, employees, and volunteers on his story of recovery after being blinded and catastrophically injured by a drunk driver. Speaking about his book, The Other End of the Stethoscope, he shared insights to assist all healthcare providers to provide excellent patient care. Over 150 people attended. On May 21st, Dr. Kadir Halimi, emergency room physician, and Dr. Daniel Sweeney, intensivist, presented Don't Let Severe Infection Take Over Your Body. Katie Choi, RN, moderated the program. 33 people attended. On May 28th, Christy Caracappa, Health Insurance Information Service Coordinator, presented to the Better Breathers on Medicare and durable medical equipment. Information was also provided on Advanced Healthcare Directives and POST forms, which stands for Physician Orders for Life-Sustaining Treatment. 35 people attended. On June 3rd, Washington Hospital held a Rose Garden Remembrance. The event provided an opportunity for the hospital community to remember those who have passed away while serving as Washington Hospital employees, physicians, volunteers, or board members. Employees Nancy Jo Edwards and Cindy McIntosh were remembered at the June 3rd event. Michelle Heading, Spiritual Care Coordinator, provided non-denominational reflections. On June 3rd, Dr. Ash Jain, cardiologist, and Dr. John Thomas Mahegan, vascular surgeon, presented Peripheral Vascular Disease, Learn Your Risk for Heart Attack and Stroke. 42 people attended. On June 5th, as part of the Diabetes Matters program, Kimberly Alvari, registered dietitian, presented Healthy or Hoax? Smart Food Choices. 30 people attended. On June 6th, Washington Hospital participated in the Four Seasons of Health Senior Health Fair. This event featured more than 100 vendors providing information for seniors. Washington Hospital offered bone density screenings for osteoporosis and information on health insurance options. 83 bone density screenings were provided. Over 500 people attended the event. On June 7th, as a follow-up from the Peripheral Vascular Seminar, Dr. Ash Jain, cardiologist, Dr. John Thomas Mahegan, vascular surgeon, and Dr. Gabriel Herskew, vascular surgeon, screened for peripheral vascular disease. This free screening involved a Doppler study of the blood flow in peripheral limbs and provided information on whether a person may have peripheral vascular disease. A total of 97 people were screened. Of the 97, 4 were found to have possible arterial disease, and 15 were found to have other vascular issues requiring follow-up. Upcoming health promotions and community outreach events. On Thursday, June 19th, from 12 noon to 2 p.m., Christy Caracappa, Health Insurance Information Service Coordinator, will present on Medicare to the Seniors in Retirement, SIRS group, at the Newark Pavilion. On Saturday, June 21st, from 11 a.m. to 1:30 p.m., Washington Hospital will participate in the Tropics Senior Health and Resource Fair. Information on nutrition and diabetes will be presented. On Tuesday, July 1st, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, will present Introduction Stroke and Risk Factors for Stroke. The 2014 Central Park Summer Concert Series kicks off on Thursday, July 10th. Washington Hospital is the co-presenting sponsor. All concerts are held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. and are free and open to the public. Washington Hospital will be providing health information and health screenings during this 6-week concert series. On July 19th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute will host the 7th Bay Area Symposium on Advances in Neurosciences. World-class neurologists, neurosurgeons, radiation oncologists, and other healthcare professionals will be speaking at the symposium. Nationally and internationally recognized experts will discuss a wide range of topics focused on neurological diseases, disorders, and treatment approaches. The program coordinators are Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. To register, call 510-791-3417. Space is limited. The Washington Hospital Healthcare Foundation Report. On October 11th, the Washington Hospital Healthcare Foundation will host the 28th Annual Top Hat Dinner Dance. This year's gala will be co-chaired by Rod Silvera and Skip Turner, the owners of Professional Home Care Associates and Neurosport, and Dr. Jan Henstorp, Chief Medical Information Officer at Washington Hospital. The co-chairs promise a wonderful evening filled with fine dining and up-tempo dancing. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the Washington Special Care Nursery, which is affiliated with UCSF Benioff Children's Hospital, San Francisco. This unit in the hospital cares for babies born prematurely or with life-threatening conditions. Funds from the gala will support patients, families, and provide technology upgrades. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the Foundation at 510-791-3428. At an event held on May 15th to celebrate Fremont Bank's 50th anniversary, Washington Hospital Healthcare Foundation was the recipient of a $10,000 unrestricted grant. The trustees of the foundation would like to extend their thanks to Fremont Bank for its ongoing support and generosity. Washington Hospital Employee Association, WIA. During the month of May, the Washington Hospital Employee Association participated in the Employee Health and Safety Fair, which was held during Hospital Week. In addition, WIA held their annual dues drive and signed up 10 new WIA members. WIA members have access to discounted tickets for local attractions, such as sporting events and amusement parks. WIA members also provide donations of time and goods to local charitable organizations. Washington on Wheels, WOW, Mobile Health Clinic. During the month of May, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, Fremont Family Resource Center, Silliman Activity Center in Newark, and the New Haven Adult School and Ruggieri Senior Center, both located in Union City. WOW also provided healthcare services to students and families at Briar Elementary School in Fremont. Washington on Wheels provided occupational medical services, including pulmonary function tests and ERT physicals, to 10 employees at Exelitis Technologies, which provides innovative, customized optoelectronics and advanced electronic systems to a global customer base. WOW also provided tuberculosis screening for 15 employees of the Newark Unified School District. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of May was 98. In June, Washington on Wheels began offering free blood sugar screenings for community members at all sites visited by WOW. These free screenings have been offered each summer since 2005 and provide an opportunity for the community to be screened for diabetes. Diabetes is a chronic disease that has no cure and can cause many serious complications, such as eye disease, kidney failure, and nerve damage. Having diabetes significantly increases one's risk of stroke and heart disease. Risk factors for diabetes includes age, family history, race and ethnicity, being overweight, having high blood pressure, and high cholesterol. A blood sugar screening consists of a quick finger stick that measures blood sugar levels and helps identify diabetes. It also is a way to monitor blood sugar levels for those already diagnosed with the disease. Visit www.whhs.com/wow or call 510-608-3203 for more information on where screenings will take place. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was May's most viewed webpage with 12,779 views. InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78 InHealth taped new programming, including the May Board of Directors meeting, a Diabetes Matters program titled Insulin, Everything You Want to Know, 2 health and wellness seminars, Do You Have Knee Pain? Learn the latest treatment options, and Don't Let Severe Infection Take Over Your Body, and a Healthy Knowledge at Noon seminar, Guilt-Free Cinco de Mayo Cuisine. The following programs aired on InHealth in May, including How Healthy Are Your Lungs?, Meatless Mondays, Heart Disease and Diabetes, and Acetaminophen Overuse Danger. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070.
Before I talk about our Employee of the Month, I wanted to let the Board of Directors know that once again we've received a Practice Green Health Partner for Change Award for a significant achievement in sustainability. And it perhaps doesn't matter to a lot of people, but I am especially proud of the fact that when we tore down Whitaker, all of it was recycled, which is a fairly remarkable accomplishment in this day and age. Paul Kelly deserves a significant amount of recognition for shepherding this program for all these years at our hospital. I also want to talk now about our Employee of the Month, Susanna Aquino. She's worked for us for more than 9 years. She was in the first group of lift team members at Washington Hospital. She's had extensive training from nurse educators and physical therapists on proper practice and importance of patient lift positioning, repositioning, and assisting. These skills have immediate long-term effect on patient outcomes, including the comfort of our patients, protecting their skin, and decreasing the potential for pneumonia, shortening length of stay by routine turning, repositioning, and early ambulation. She is described as someone who is very self-motivated and always willing to help. She gets frequent calls to assist on all nursing units and always responds quickly and with a great attitude. She also assists central transport with moving patients to needed destinations. She's a prime driver in the daily weights assignment being completed accurately and timely. And many disciplines depend on those daily weights, like pharmacy, food and nutritional services, and dialysis, just to name a few. She's always friendly and ready to assist with a smile. She's gentle and caring, which is exactly what we want for our patients. She frequently brings lunch to work for her friends, and she's a reportedly very good cook and makes great Filipino dishes. She's always willing to help. She never says no and always arrives with a smile. That's how John Peterson, our transport coordinator, describes her. She practices our patient-first ethic, and I feel like we're very fortunate to have her with us. See, there is good news.
Here we go. We'd like now to have our construction report from Ed Fan. Now that we know that Whitaker was all recycled.
Thank you, Dr. Stewart. So we continue to sort of move along in our schedule for construction, and we're at sort of a cross-sectional point here on a couple of jobs. So let's first talk about the parking garage. We go to the Planning Commission tomorrow night at the City of Fremont. I think I've described before that our permit process is going through the city permitting department at the same time. So once we get through tomorrow night's meeting, and from everything I understand, it's still on track to go through and get passed tomorrow. The permit should be delivered to us shortly thereafter. And at the same time, we're also getting some FAA permits. So we've already kick-started our bidding process in anticipation of getting the approvals this week. So we should have bids coming back by the middle to the end of July for the garage, and then be able to move forward with that. So that project is moving along, and we anticipate being under construction there by the end of the summer. On the Hyman Critical Care Pavilion, sort of more of the same of what I've discussed in the last couple of months. Still underwent demolition process. This is a shot of the water tank, the well tank for well water that is utilized on a daily basis for things like sprinklering lawns throughout the campus, and was also a backup in the case of disaster water supply. So this is in the footprint of the new Hyman Pavilion, so it had to be removed. By the way, as part of this whole project, we would be drilling a new well back by the new central plant and getting backup water set up in that area. You can see that this is showing you some of that area around the well that was demolished. This is just worthy of note in that this is the pad that the former MRI and then Fast Track building sat on. And this is still in existence because we have electricity and gas that runs through this to the annex, the emergency department annex. We are currently relocating this, and we anticipate within the month to be done with that. And then we'll come back and demolish this pad. Same contractor to mobilize and come back and finish this demolition work, and then we're pretty much done. We probably will undergo a little bit of investigative digging to make sure that there's nothing else that we don't anticipate under the ground here, so before we start excavation. But you know, we're pretty close to being completed with all the demolition that's tied to this. And here you can see we have to, as part of our EIR, we're supposed to do things to mitigate dust. And so you can see some work. Previous, you can see them hosing down things. That's a ongoing issue. And then we'll probably be planting some grass material back here that we have to do to mitigate dust until we undergo the big dig, let's say. Okay. Any questions I can answer on demolition and what's happened so far?
I don't think so.
Thank you.
Thank you, Ed. I'd like now to have a report on our organ donor network from Kristen Ferguson. If Nancy, if you could introduce that.
I'd be happy to give you a little information about Kristen. I think most of the board have met her. She graduated from California State University, Hayward in 1990 with a bachelor's degree in human biology and a minor in public health and public speaking. She spent 14 years working in the technology industry as a software sales rep and director of sales. In 2004, Kristen entered nursing school at Ohlone College and came to work at Washington Hospital, working as a program coordinator for the internal medicine hospitalist program. In 2006, she graduated from nursing school and began her nursing career as a staff nurse at Washington Hospital. She's worked in various leadership roles over the next 6 years and as a charge nurse and a bed management nurse. In 2011, Kristen was selected to participate in a one-year administrative intern program working under the leadership of myself and the associate administrators. In 2012, she graduated from UOP with a double master's degree in nursing and healthcare administration. In May of 2014, Kristen became the chief of compliance. She's also certified in healthcare compliance.
Thank you, Nancy, for that introduction. Tonight I have been asked to present information on the work Washington Hospital is doing in relation to organ donation and the collaborative relationship we have with the California Transplant Donor Network. The hospital works closely with the CTDN to execute the identification, suitability, authorization, placement, and recovery of organ and tissue donation. Through our collaboration, the hospital and California Transplant Donor Network are able to assist families at a very difficult time in helping them navigate through the decision-making related to organ and tissue donation. The California Transplant Donor Network is a federally funded, designated nonprofit organ procurement organization with whom we work closely to facilitate organ and tissue donation for transplantation. Currently, there are 121,160 individuals across the United States waiting for an organ match. Of the 121,160 individuals waiting, approximately 24,000 or 20% of those individuals are listed at a California transplant center. So this slide depicts the growing, widening gap over the last decade between those individuals waiting for an organ match and those actually donating organs for transplantation. The green bars on this graph represent the number of transplant over the last decade. You can see that this number has remained fairly constant over the last 10 years, and the number of transplants aren't growing the way they need to be. The yellow bars on this graph depict or represent the number of individuals who are actually in need of an organ transplant. So what this data tells us is that over the last decade, there has been a steady decline in need for organ donation, and yet the number of individuals who are actually transplanting or donating organs for transplantation is not meeting that need. So what this clearly tells us is that there's still a lot of work that needs to be done in educating and informing the public about organ and tissue donation, and that includes our own district community. So this slide represents the current national waiting list, and it breaks down the organ types that these individuals are waiting for. So each one of these organs here on this list actually represents an individual. These individuals are waiting anywhere from 30 days to up to 8 years for receiving an organ. The largest group are those waiting for a kidney, and in the United States currently an individual has to wait an average of 8 years to receive that kidney for transplantation. Individuals waiting for liver make up the second largest group with 15,886 waiting. And there are currently 3,706 individuals waiting for a heart for transplantation, and this makes up the third largest group of individuals waiting. So this graph shows the actual number of transplants that occurred in 2013 through the California Transplant Donor Network. The largest number, again, was kidneys, with 444 transplanted in 2013. There were 225 livers transplanted, 136 lungs, 80 hearts, and 34 pancreata, or the pancreas, and one intestine. There were a total of 920 organs transplanted in 2013 through the CTDN, our California Donor Network. So what is the impact of organ and tissue donation? Well, it's quite significant, as you can see. One organ donor can save up to 8 lives. One tissue donor can improve the quality of lives for up to 50 individuals. Tissue donation includes eyes and corneas, heart valves, skin, bone, tendons, cartilage, and veins. So now that I've shared a little bit about the background about the work we're doing with the California Donor Network, our collaborative relationship and what we're engaged in, I'd like to share some real-life stories about some very special patients that were cared for here at Washington Hospital, and I'd like to tell their stories about the gift of life they gave to others through organ donation. On February 22, 2014, a 30-year-old female from Washington Hospital saved 5 lives. Through her donation, a 43-year-old woman from the Central Valley in California received a right kidney. A 63-year-old female from Northern California received a left kidney. A 63-year-old female from Northern California received a partial liver. A 3-month-old infant baby girl from Arizona received a partial liver. And a 56-year-old female from the Central Valley in California received a heart. On March 13, 2014, a 36-year-old female from Washington Hospital saved 4 lives. Through her donation, a 33-year-old man from Northern California received a right kidney. A 51-year-old man from the San Francisco Bay Area received a left kidney. A 49-year-old female from Utah received a liver, and a 70-year-old man from Southern California received a heart. This young woman's lungs were also recovered, and although they could not be transplanted, they were donated to science and research. So as you can see, Washington Hospital is involved in many, many ways of helping to save the lives of our community and those who are waiting for organ transplants across our country. We're very proud of the collaborative work we do with the California Transplant Donor Network. We're a part of being a part of that process that facilitates at a very, very difficult time and in a family's life, the education, the support, the information that we can provide to these individuals, and hopefully bring them some hope during a very tragic time through donating their loved ones' organs and giving the gift of life to others who are in need. So I can answer any questions for you at this time if you may have any.
Thank you very much, Kristen. I had no idea there was such a large gap between those needing organs and
Yes.
those donations. That was shocking to see.
And it's growing every year.
Yeah, that's amazing. Pat?
I have a question.
Sure.
I hate to admit my ignorance, but I was not aware of the intestines being transplanted. In my mind, I have this vision of all of the intestines. Is this the whole thing, parts of it?
They've done both, actually, yeah. It depends on the need. Yeah.
Depends on the need.
It's pretty incredible what they can do. Yeah.
I didn't know that they were doing that. That's quite interesting.
Yeah.
With good success?
From what I've read and researched and what I've been shared by the CTDN, yes.
Really?
Yeah.
Okay. Thank you.
You're very welcome.
Any other comments or questions? Thank you again, Kristen. It was
Thank you
very
very much.
informative. We'll now have our quality report from Mary Boren. Nancy, if you could introduce Mary to us, that'd
Very
be
happy
great.
to introduce Mary. She's going to become more of a fixture here. You'll be seeing her every month, presenting quality information. She's been employed by the hospital for 6 years. She received her Bachelor of Science in Nursing from the University of San Francisco and worked in med-surg and the emergency department nursing for 7 years, and then transitioned into infection prevention in 2009. She obtained her Master's of Science in Nursing from the University of San Francisco. She is a certified clinical nurse leader and is certified in infection prevention. In 2012, she became the Director of Quality and Resource Management and completed her doctorate in nursing practice from Samuel Merritt University. She's a very accomplished young lady.
Thank you, Nancy. So this evening I wanted to present some of our recent data from quality for March quarter ending March 2014. We look at various indicators in quality, as you know, that have been brought here before. But just to review, we're going to start off with going over our core measure, compliance. Core measures are really indicators that we monitor on a day-to-day basis here in the hospital to assure that patients are getting a standardized treatment that can improve their patient outcomes as well as possible. These are things like when patients come into the hospital and have a heart attack or pneumonia. There's a lot of scientific evidence behind these that it shows if you implement a bunch of interventions at the same time, you can improve your patient outcomes. So that's basically what we look at with core measures. To start off with, patients that come in here with heart failure, we are required by CMS to make some appropriate interventions with them. And one of them is looking at their left ventricular systolic function. Basically looking at how strong their heart is. So we test those patients when they come in, and we've done well in this area for the last quarter. You're going to be concentrating on the light blue column for quarter ending 3/14. So for the LVS function, we were 100%. All of those patients received that test. The state national benchmark is 99%, so we're a little bit above on that. And then also these patients are required to get an ACE medication upon discharge to help lower their blood pressure, and that's also been an area where we've done well the last quarter at 100%. State national benchmark for that is 97%. Moving on to patients with pneumonia. We've done well there the last quarter. What we're really focusing on in this population is assuring that these patients get appropriate antibiotics for the type of pneumonia that they have. And we have been at 100% for that, putting us above the state and national level. State is 96%, national level is 95%. With patients who have an acute myocardial infarction, otherwise known as a heart attack, we've also had good success at discharging these patients on aspirins. Chris Henry actually mentioned some of these indicators, and this is one of the ones that he was referring to earlier. All these patients need to leave with an aspirin on prescription. So we were able to do that at 100%. An area where we've had some type of focus on improvement has been with regard to when a patient comes in with what we determine to be an AMI or a heart attack. The standard is that you get them into the cath lab in 90 minutes or less. As you can see, the national benchmark for that is 96% and state is 95%. We were at 86% this last quarter because we did have 2 patients. This is a reflection of 14 patients that needed to go to the cath lab. And of those 14, 12 made it in less than 9 minutes. And then we had 2 that did not. They made it a little bit over 90 minutes. One of the patients came in with an atypical presentation. This patient came in with abdominal pain. The patient was younger, and so as a result, got an EKG later on. So that delayed our time a little bit getting to the cath lab. So after this, we changed our standard for how we do EKGs in the ED. Now, every patient who comes into the ED who's 45 or older and complaining of any pain above the umbilicus or belly button has an EKG. So a lot more people are getting EKGs now, so we won't miss any atypical presentations. And our other patient was more related to a systems issue in the hospital that we've been working on. We have a special task force called a STEMI working group that is really drilling down on these cases and trying to find ways that we can improve and save every minute possible. So we're expecting those outcomes to look good next quarter. The last one is patients need a statin prescribed at discharge. So we had a couple patients that did not receive this. Out of 55, 52 got it, but the 3 who didn't, there were just some transcription errors. And we're working with our new electronic medical record, as you know, is Epic, to help us give us alerts on these patients at the time of discharge to make sure that they're getting their appropriate statins. We also look at patients who come in and have surgery. Want to make sure that they are having all the proper interventions to improve their outcomes. A huge focus on this is making sure that they don't get infections. So you'll see that 3 of the indicators have a focus on antibiotics. We like to make sure these patients have antibiotics within an hour of their incision. We were able to do that last quarter at 100%. The state and national level is 99%. We also selected the appropriate antibiotic in these cases 100% of the time. State and national benchmarks are 99%. The other part of it is that when you prescribe an antibiotic right before surgery and you give it 1 hour before the incision, we want to make sure that we don't just keep giving that antibiotic. We want to be really careful and make sure we give them appropriately. And part of that is discontinuing that antibiotic within 24 hours, which we had at 100% compliance. The national level is 98 and state is 97. The other thing we want to do is, because these patients have decreased their mobility, we want to make sure that we are decreasing the risk of the patient developing a clot while they're here. So we do venous thromboembolism prophylaxis. We were able to get these patients covered for that at 100% of the time. State's 98%, national's 98%. This is things like putting on mechanical devices on their legs to make sure that that helps them with their circulation, giving a certain type of medication that can stop the development of a clot. So I think we're doing well in that. SCIP has these other indicators also of giving a beta blocker right before surgery. We did have a case that fell out on this, so it put us at 97% compliance when the national level is 98 and the state is 97. So we were fine for state, but national just a little bit under. And that's just a reflection of one patient that did not get the beta blocker because they couldn't take anything by mouth before surgery. And the clinical practice was right on this. It was a good choice not to give this patient the beta blocker. But CMS is very specific on how they like this done. And one of the parts is that you have to document the rationale for why you didn't give the beta blocker. So that was a piece that was missed. And another good thing about having Epic is that it's able to give us best practice alerts to say, okay, you don't want to give a beta blocker, that's fine, but explain why. So we have built some reminders in there that will be helping us with those. We also, if a patient comes in and has a heart bypass, that's the cardiac serum glucose monitoring, they want these patients to be monitored very close to make sure that their blood glucose does not go above 180 at any time within the first 24 to 48 hours after this surgery. This used to be 200, and then January 2014, they changed it to 180. So we're sort of adapting to that. We did have one fallout that sort of dropped us down to 95%, just 1% below state and 2% below the national benchmarks. What we've done is we worked especially with the critical care team. They've changed their insulin protocol, and we've now been able to really watch these patients to make sure we stay at 180 or below. And then the last piece is making sure that these patients get their urinary catheters removed within the first or second day of their surgery. It's really important to do that because if you leave in that device for too long, you run the risk of them getting a catheter infection. So we've stayed within the goal on this at 98%. We're a little above the national and state benchmarks, which are 97. We also look at patients who are not spending the night in a hospital, but are having surgery outside of the hospital. The areas we look at, again, are related to antibiotic timing and selection. Both of these areas, for the antibiotic timing, we were at 97% compliance, a little bit below for the national level at 98%. It's very close. This particular patient did get their antibiotic, but it was 4 minutes past the hour, and so therefore it falls out. But we were very close. And they did have the right antibiotic selected, which is really important. We're at 98% compliance for that. National is 98, and the state's 97. Another area in quality that we really focus on is how to prevent the spread of infections. The patients, when they're in the hospital, become at risk for developing and acquiring infections while they're here. The good thing is there is a lot of evidence out there about how we can prevent the spread of hospital-associated infections. And so our program, which is under quality, is infection control, has implemented a lot of things to prevent HAIs. We have a program coordinator, and then we have an infection preventionist. They work with every single aspect of the hospital. We work with pharmacy, we work with environmental services, we work with nursing, we work with ancillary services to make sure that we are doing the best we can to improve these outcomes. Part of that is looking at patients who have central lines. Anytime you have a medical device and you insert it into a patient, you run the risk of them developing an infection because you're taking something from the outside and implementing and inserting it to a sterile area. So especially when patients are in critical care, they need a large access and easy access to their veins to give medications and fluids. So these patients end up with having a lot of central lines. We have actually done well in this area. You can see the way that the CDC likes for us to benchmark this is what's called the standardized infection ratio. And in simple terms, it's the number of infections that you have over the number that they expect you to have. So really, if you are above a 1 with your SIR, you're doing worse than the rest of the nation. If you're below a 1, you're doing better than the rest of the nation. And if you're at a 1, you're about the same as a like hospital in your nation. So the red line is the 1. So anything below the red line means you're doing better than, which is what's happening for us with CLABSI. We did have 3 CLABSI infections. We do take them serious even when we are below our benchmark. Each one is really looked at. It's reviewed by Dr. Martin, our infectious disease doctor. We work with the PIC nurse teams here, and we look and say, what happened with this case, and we do a root cause analysis and focus on prevention efforts with those. But for right now, we feel comfortable that those are where there should be. Another area where we've done really well last quarter is with our surgical site infections. California requires that we survey over 27 surgical procedures every month. It's the highest, strictest requirement for surgical site infections in the United States, and we've put a lot of effort in watching these. Last quarter, we only had 1 infection with this, and it was a really mild surgical infection that healed fine, putting us below the benchmark. Again, you can see we're below the 1, so better than what was expected. So we have less surgical infections than what the CDC would have expected. A challenge that we're facing right now in the infection prevention program and just in general hospital-wide is trying to reduce our C. diff rate of infection. C. diff is it's a spore. It is present in the stool. It's incredibly hard to treat with antibiotics. It's very virulent out in the environment. If stool gets out into the environment, it can live on the surface for over 60 days. Typically, bleach is the only thing that kills it, and washing your hands with soap and water. So in general, the nation has seen a rise in these what we call multiple drug-resistant organisms that are very hard to treat with antibiotics. And in this, you can see we're above the red line. It's been a challenge for us, just as it has been for other hospitals. This last quarter, we did have 20 hospital-associated infections with C. diff. What that means is that the patient came into our facility, was admitted, and 3 days later shows signs and symptoms of C. diff. The test comes back positive, and the CMS says at that point we call it our hospital-associated infection. But what I'm very pleased we have been doing in this program is that the administration took this very seriously. Dr. Martin brought this data and showed it to the administration, and they have given us a lot of resource in trying to bring this down. That's included environmental services, cleaning on a whole nother level. We clean every single room with a new product called Steriplex, which gets rid of C. diff within 5 minutes. We're using that throughout the entire hospital. We're taking how we prescribe our antibiotics very seriously. Antimicrobial stewardship looks at all antibiotics in the hospital, how they're prescribed, if it's the right medication, if it's the right dose. We've been doing that for a couple years, but really aggressively looking at that now because antibiotic use is associated with C. diff. So it's a risk factor. If you've been on antibiotics, you're at higher risk for developing C. diff, unfortunately. The other part of this is hand hygiene. It's the best means of stopping the spread of infection in a hospital or in anywhere, actually, even in the community. And we've really spent a lot of time on that in the last year, sort of educating people about the importance of hand hygiene and about what we need to do, and getting people out to observe all of our healthcare workers. Every discipline in this hospital is observed to assure that they are washing their hands appropriately. And we take the results of that data very seriously. And sometime in the future, we'll probably be able to bring you some data on that program and what we're doing with it. So as a result of these interventions, what I am hoping will happen and feel very confident is that you will see this number come down over the next quarter. Catheter-associated urinary tract infections are another area that we look at very seriously, because anytime a patient has a catheter and they're in the hospital, again, it's a medical device. It's going to put you at a higher risk for getting an infection in your urine. So you can see we've been under the red line for all these last quarters. It's for the past 5 quarters, in fact. Last quarter we did have 4, but we're still having less than what the CDC would expect out of a hospital this size with this patient population. Another area of multiple drug-resistant organisms, again, that's the organism that's very difficult to treat with an antibiotic, is MRSA, methicillin-resistant Staphylococcus aureus. Some people may have heard this called MRSA. It's very challenging across the United States. There's been I was reading on the CDC that there's actually been a national spike in the MRSA for the last quarters, and you can see it's also been reflected here. We did have one case. This was a case of a patient who came into the critical care, didn't have any signs or symptoms of this particular infection. Then we did lab resulted that it's been in the blood. With multiple drug-resistant organisms, when you do a treatment like all the things I mentioned before about C. diff, when you do that, you also can bring down MRSA. It's because it's similar. It's a multiple drug-resistant organism. So all the things we're doing around C. diff, we're hoping will also work to bring down our MRSA rate. So you can see we're a little above the benchmark. Another area that quality is involved in is looking at nursing sensitive indicators. We work closely with nursing to make sure that we're providing the best quality care in conjunction with them in their efforts. An example of this is looking at our pressure ulcer prevalence. So patients that are in the hospital, as you know, have less mobility. They're in bed a lot longer. They're sicker, so their skin is at risk for breaking down. And we have done well in here. You can see it's kind of up and down, but basically under the red line, CalNOC is our benchmark for this. We have a team of people that go around and do direct observations of this to make sure that they look at our charting, they look at the patients, and we've been good at 0.60 here without having a problem for the past 4 quarters, which is significant. This is a hard thing to keep in control. Another area that especially is reflective of nursing sensitive indicators, our patients are at risk for falling, obviously. So this slide is showing you moderate plus injury falls. So these are patients that fall and have an injury, and this last quarter we were able to drop down to 0 with no moderate injuries and falls. I think a lot of that has to do with the falls reduction program that we've implemented. We do a lot to prevent these patients from falling. We put them on very low beds to the ground. We do a lot of rounds. We've implemented a no pass zone, so when you are any type of healthcare professional walking by, if the call light is going off, you need to go into that patient's room and see and assure that they need help. And the data shows that if you do that and you have more people putting their eyes on these patients, you decrease the risk of them falling. So we've implemented that here, and looks like we're having some pretty good results with it. The Institute for Healthcare Improvement, which is IHI, is another national organization that is very involved in quality. They provide us standards and guidelines for how to improve quality in your hospital. We've been involved with them for many years, and one of the things that they look at is MRSA, what I mentioned before, that drug-resistant organism. They would like and have recommended that we do a surveillance for MRSA, so meaning that we test patients who come into critical care for MRSA. We just swab their nose within the first 24 hours they're here to see if they come back positive for MRSA. That way we can isolate these patients as soon as possible, which also decreases the risk of that infection from spreading. In California, they take this a little step further than IHI and the rest of the nation. There are many populations we have to do. This data you're seeing right here is critical care. It's 98%, and in this quarter, we screened every single patient that was transferred into critical care with the exception of 10 patients. That's why it brought us down a little bit to 98%. Our goal is 100%. But the 10 patients that were eventually screened, they were just screened a little bit past 24 hours. We share this data with the nurse manager. She goes back into each one of these cases, discusses it with the staff taking care of them, and we just give some education and a reminder about how important it is to screen these patients so we can identify their MRSA early on. But I was mentioning before about California, we also are required to screen patients that come from a skilled nursing facility because they're at higher risk for having MRSA. We screen all patients here that are having inpatient dialysis. We screen every single patient that comes here who's been at another hospital in the last 30 days. And we screen all patients who have a history of MRSA. So I feel like we're looking for this bug as much as possible in the efforts to try and catch it and isolate it and treat it. And Joint Commission obviously plays a huge impact on quality. We want to implement the national patient safety goals as well as possible. One of them, as you know, is about communicating with your healthcare professionals when you're at the end of your shift. This is called handoff communication. This is essential that this happens. There is so much evidence and data that says if you get healthcare practitioners face to face at the end of their shift having a discussion about what occurred with the patient, you don't run the risk of things sort of falling through the cracks. And this we've done really well at. We do direct observation of this. There's a large number of people who were observed for handoff communication in this quarter. It was actually 349 of these handoffs were observed. We spent a lot of time observing this, and we did find 100% handoff communication occurring. Like I said, absolutely essential. The other part is patient identification, huge part of preventing errors in healthcare. We've done really well on this. That's another thing we do by direct observation to make sure that the staff is identifying patients before procedures, before giving medications, verifying name, verifying medical record number, and date of birth. Had some good success there for the last 2 quarters, especially have been 100%. Procedure timeout. Sure, a lot of you are familiar with this, that before we start any invasive procedure, there's a moment where everybody needs to take a moment. It's the timeout, verify the patient's name, verify the patient's procedure, verify which side you're doing your procedure on. These are sort of ways that we can prevent errors from happening in procedures. So we've had a little bit of a dip in the goal. Our goal is 100%. We obviously want to be doing a timeout 100% of the time with any procedure, but we were at 99.7. We went back and did an investigation on these cases, and we think we found a trend in, it was just in the cath lab. What had happened was when we went back and interviewed the staff, compliance has worked with the staff, the timeout did definitely occur. There's a part where they need to document it in the medical record, and that's where we fell out. So we've done in-services a lot there and talked about the importance of, yes, doing it, of course, but then documenting it, because that's, our proof that it happened. So that's more related to documentation, and we've been working very closely on that. Readmission rates. This is something that has gotten a lot of attention in the media over the last couple years. These are Medicare patients that are admitted to the hospital for the diagnoses of heart failure, AMI, otherwise known as heart attack, and pneumonia. We look at these populations very closely to watch them for readmission within 30 days. That's what Medicare is focusing on right now. Our pneumonia readmissions you'll see that January, February, and March are there for the quarter. We did have 7 of these patients come back, and it was 7 patients out of 50, and it's 12%. So we had looked at these to see, the goal is, did you miss anything with the pneumonia? Was there anything we could have done to prevent this patient from coming back? But what we found is these people were coming back for different things. One person came back for a viral infection when their pneumonia was bacterial. We have fever, anemia, these sort of things. But Medicare still looks at that. It's called all cause. If a patient comes back, if you have a patient who's admitted here with pneumonia and then 2 weeks later they unfortunately fall and fracture their hip and they come back, Medicare does count that as a full readmission. So we have to report and look at that data. Heart failure readmission reduction is another part that Medicare is looking very closely at. In our last quarter, we had 9 of these patients return. Again, same story. We look at all these. This we look at very carefully because these patients come back because they have such chronic illness. They're much more likely to come back. And Dr. Nicholson mentioned earlier about us being responsible for taking on educating these patients and helping them take care of themselves. And that's absolutely true in this case. We have a nurse that is dedicated. His one full-time job is to go around in the hospital, look at patients who have heart failure every single day, work with them on doing just that, trying to learn to take better care of themselves. We go over diets with them. We make sure they have a primary care physician they can work with after discharge. These patients, when they leave the hospital, our goal is that 100% of them will have an appointment made with their primary care physician so that we have some follow-up on them so that they can watch their weight and make sure they're taking their medications and following their diets. The next goal in this program is to get some healthcare organizations out there, home care, working with us to establish that maintaining and helping these patients at home so they can avoid having to come back here. AMI, again, is the last area that they're looking at. This case was, again, another 7 patients admitted, another just sort of range of causes about why these patients came back. And this puts us at about 33% rate of return on these AMI patients. The ultimate goal would be to sort of expand the role of what our readmissions nurse does to look at these AMI and pneumonias included into the heart failure. So we are working with various multi-disc teams in the hospital to look at reducing this readmission rate. And those are the areas that we're primarily focusing on in quality. Thank you. If you have any questions?
Appreciate that, Mary. It's nice to hear from you. We look
Thank
forward
you.
to hearing from you in the future.
Thank you.
There's just one area where I want to have repeated,
Okay.
and that is the readmission for pneumonia. If a patient is in the hospital for treating pneumonia, they go home, fracture their hip, come back, Medicare will not pay for that.
It's all-cause readmission. Yeah. So these
All-cause readmission.
exactly.
Another way of, earlier we were talking about cost reductions and the way that CMS is looking to pay less for procedures. This seems to be on the area of absolutely ridiculous.
Oh, it is, that's a great example of that. Yeah. It's
Anyway,
unfortunate.
I'm sorry, but I wanted that repeated. It's,
Nope, but
I
it's
think
the
that's a
truth.
very
Exactly.
important
It is.
issue.
Very frustrating.
This is that patients who become aware that the hospital's not going to be reimbursed might stay away out of a sense that it's not fair to the hospital. And there are some seniors that would take on a position like that. And they have a relationship with the hospital. They love the hospital. They love their doctors. And they don't want to harm the hospital. And I think the worst of all possible outcomes would be if somebody did not come when they needed to.
Yeah. Absolutely.
Pat, you had a comment.
Well, I had a comment and a question. It just came into my mind, and I don't know why I remembered it, because it was many, many years ago. I attended a little seminar that was presented by a coroner. And the way that they diagnosed was a little bit different in finding the true cause of death. So somebody fell, that wasn't the fall that caused the death. It could have been something preceding that. So all of a sudden it came into my mind that the patient came in here for heart failure. That was your example. They fell, they came back in, and we are going to be penalized.
Yes.
And it might be the same way as the coroner was looking at how they diagnose. The fall would not have occurred had not the patient had heart failure. So we didn't fix the original problem, which resulted in the second problem. Therefore, we're at fault. It's very weird
It's like an association.
thinking. It just doesn't make sense. But that's what it reminded me of, is how a coroner's office will actually diagnose.
Oh, that's true. And that's what I meant when I said we try to look at these patients that are coming back to see if there's any association. Is there anything we missed that we could get to make sure that nothing to do with that primary diagnosis comes back and is a part of why they were readmitted?
Right. It's the hospital's responsibility to cure it completely, or you're at fault. Now, my question, if we'll go back to the C. diff, because I want to make sure I understood that. With MRSA, there is a swab that you can do that will indicate whether or not they have MRSA or not. With C. diff, there is not?
There is actually. One of the reasons why we found a lot more C. diff here in the last couple of years is because we have changed to a much more sensitive type of test. It's also PCR, and it's exactly like MRSA. You take it, you test the stool, send it to the lab. We have a great turnaround time because we do the testing here. We know if these patients have C. diff within 45 to 90 minutes after the test. So yes, we do have that.
Because you said 3 days, after 3 days, if the C. diff patient ends up with C. diff, that is a negative mark against the hospital. Okay. If it's so common and lives so long on surfaces, how do we know for sure they didn't enter the hospital with it in the first place?
That's what's so unfortunate about this criteria is that exactly. So you don't know for sure. So you can look at some things. Let's say if the patient came into the hospital on the first day and they were symptomatic for C. diff, right? Like they had loose stool, and we would test it. We try to test right away. We try to test as quickly as possible so that it can be identified. And if we do identify it within less than 3 days, it's called community onset C. diff. And we do have a large volume of community onset C. diff because it's heavily in Northern California. So those patients, yes, you can test if you have a symptom. But there are circumstances where the patient comes in, they've been here for 3 days, they have not been symptomatic, they've received a lot of antibiotics, they finally start to have the symptoms of C. diff, then we test it because we can't test it unless the patient is symptomatic because that's the way the test works.
Okay.
You can only test somebody who has the symptoms of C. diff.
So we're kind of in a catch-22.
We are. There's a lot of literature out there and Association for Professionals in Infection Control about this, that they've cut the line so tight that, it's just yours. If it takes you more than 72 hours to detect it, your hospital owns it as a hospital-associated infection.
Okay. Thank you for the explanation.
No problem. Thank you.
Any other comments?
I think one of the things to emphasize is not all hospitals use the same test, and we're using a particularly sensitive one. And so our C. diff rate may look high simply because of the test that we're using. Other hospitals aren't using the same kind of test and determine that there's less.
Okay.
Good point.
Thank you again, Mary. We're now ready for our finance report. Get to hear from Chris again.
Okay, tonight we'll be looking at Washington Hospital's operational and financial results for April 2014. Average daily census for April came in 19.3 below budget at 152.8. We had 882 admissions. We'd expected 957. Our patient days came in below budget at 4,583. Including, we also had outpatient observation days for April that were 91 below budget at 250. Our average length of stay came in below budget at 4.97. We'd expected 5.39. Moving in utilization, our case mix index actually landed right on budget, and I had that checked 3 times because that's unusual. At 1.537. We had 133 deliveries in the month, about 14 below the budget. Surgeries were 60 below budget at 328. That includes joint replacement cases that were 37 below budget at 108. That was really driven by a physician vacation during the month. Neurosurgical cases were 7 above budget at 21. We had 9 cardiac surgical cases. We had expected 13. Cath lab procedures for the month came in 7 above budget at 389 in April, and our outpatient visits came in about 1,100 below budget at 7,586, and again, that volume being driven in the lab. We're just not seeing the outpatient lab volume that we have in the past. The emergency room visits for the month came in at 4,061, about 315 below the budget. Still a high volume for that small space that those folks are working in. This was the mix in the cath lab for April, and we did have some shifts in this mix during the month. Cardiac procedures made up 36% of the mix. In March, they had made up 42%, and that shifted to our neurointervention, which in March was 8% of the mix, and interventional radiology in March was 10%, and in April ended up at 12%. So again, a shift in the mix of procedures in the cath lab for the month. Moving into productivity, our productive full-time equivalents for the month came in 93.1 below budget at 1,206.8. We had 196.4 non-productive FTEs for the month, giving us total FTEs of 1,403, about 58.5 below what we expected in the budget. Our FTEs per adjusted occupied bed, which is our productivity measure, came in about 0.31 above the budget at 6.71. Moving into the financials, Total patient revenue for April came in about 7.8% below budget at $165,748,000. Our contractuals for the month landed at 75.57, about a percent below the budget. What's really pushing that is the announcement of another intergovernmental transfer program that is being driven by the District Hospital Leadership Forum in the state. You've heard Nancy and I talk about the District Hospital Leadership Forum in the past. This is a group of district hospitals that have gotten together to take on reimbursement issues. This was one of the first successes they've had, and they've championed this program over the last several years. And what it does is, because the state does not put enough money up for the Medi-Cal program, it leaves a lot of federal matching dollars on the table. So what the District Hospital Leadership Forum has helped us do is create a program with the state whereby the hospitals themselves will put up the money, the state will take that money, go get the additional federal matching dollars, bring it back to the state. Of course, they don't do this for free, and they rake off about 10% of that money, and the rest comes to the hospital. So we did receive an announcement in April that the program will happen again this year, and our share of the additional money is about $2 million. So we see that reflected actually in a reduction of some of the Medi-Cal write-offs we had during the year. So we ended April with net operating revenue about 3.8% below budget at $40,669,000. Operating expenses for April came in 7% below budget, about $3 million at $39,998,000. Largely driven in the areas of salaries and wages with our lower FTEs. Also related payroll taxes and lower health and welfare costs were reflected in our lower benefits numbers. Again, our provision for bad debt was about $1.5 million below what we expected in the budget. That was really driven by a couple of things. One, the lower gross revenue and lower activity overall, but two, private pay patients as a percentage of total revenue were less than what we had expected at 2.9%. We usually see that around 3.4, 3.5%, and that amounted to about $1 million in lower bad debt for the month. So we ended April with an operating bottom line about $1.4 million above the budgeted loss at $671,000. Non-operating income for the month landed at $1,778,000, giving us a total bottom line about $1.1 million above budget at $2,449,000. So some more good news tonight. Quick look at our Financial Accounting Standards Board presentation. This differs from the last presentation in that this is really how the financial markets might evaluate us. We remove our property tax revenue that supports our general obligation bonds from our non-operating income and our unrealized loss of about $171,000 on our investment portfolio to end up with non-operating income from a FASB perspective of about $301,000 and a total bottom line about $1.2 million above the budgeted loss at $972,000. So are there any questions on April?
I see none. We can move on to our operations report.
These are the preliminary results for May. In May, we saw 969 patient admissions that resulted in an average daily census of 154. So 1.9% lower than what we had budgeted. And our average daily census recorded a year ago was at 163. So you can see a deterioration in volume. The outpatient observation equivalent days of 227 were lower than budget. That's a good number, because when we have extended stays in observation, a number of things happen. One, we don't get paid for the inpatient services we've provided, and the other is the patients get stuck paying Part B. So to get those days down is beneficial both to the hospital and to patients, and to get decisions made about whether a patient's going home or going to be admitted on a more timely basis is a critical importance to the hospital. The average length of stay for adults and children in May was lower than budget, came in at 4.86. The birthing center saw 159 deliveries in May compared to a budget of 164. Our newborns also totaled 159. In surgery, we had 339 surgical cases, so 42 cases below budget. Our cardiac surgical cases came in 5 below budget. The neurosurgical cases, however, came in 14 above budget, which is a good result. Our joint replacement cases were 40 below budget. We had both John Dearborn and Alex Saw go on the same days, and so the surgery schedule was truncated. As those two catch up, ultimately the volume will come back to us. Our surgical minutes, which drive operating room charges, are something that's interesting to look at. They were below budget by 16.3%. Our inpatient surgical minutes were below budget most significantly at 19%, but the outpatient surgical minutes were more than expected, so it's a shift from outpatient to inpatient in terms of resources. I'm sorry, exactly the opposite as resources are utilized. We had 634 cases at the outpatient surgery center. We had planned for 609, so they were functioning above budget. For the month of May, the total cases seen in the cath lab were 350 versus a budget of 417. There were lower than expected volumes in the cath lab for interventional radiology procedures and also PTCAs. And cardiac catheter procedures were 20 below budget. Overall, the inpatient cath lab procedures came in at 15 more cases than we anticipated on the inpatient side, and the outpatient procedures came in at 82 cases less than had been anticipated. I don't understand why that balance yet, but that's something that we'll look in more detail for next month. In terms of our non-emergency outpatient visits, we had 7,277 in May. This came in lower than budget. We had planned for 8,908. The emergency room recorded a total of 4,451 patients, daily average of 144. This is about a 2.5% below the budget performance. Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,848 patients during May, which was more than the budget, which had been planned for 3,828. That's a significant positive variance. The total system in emergency room clinics for May came in at 8,299. We had budgeted 8,394. In terms of full-time equivalents for the month, we had 1,373.8 FTEs, including 17.4 agency personnel, the bulk of which are in information management and related to specific projects with the EPIC system as the 2014 update comes. These are people that wouldn't be here permanently. The FTEs came in 142.1 lower than our budget. So we're beginning to be a great deal more effective in controlling personnel utilization. The FTEs per adjusted occupied bed were 6.54, which was below the budget. Productive FTEs were below budget by 154.3 for the month. Preliminary information on the patient mix indicates that the inpatient revenue for the month of May amounted to approximately $119.6 million, compared to the budget estimate of $137.1. Of this amount, 56.4% was Medicare, including Medicare HMO, and 19.7% was Medi-Cal. So you can see that government program revenue is becoming progressively more dominant
And it is very hard to come up with a margin when your major payers are paying below cost. This is a big problem. We had, let's see, total government program revenue for May coming in at 76.1%. That's a lot. The total inpatient revenue versus the budget of 72.7%. HMO PPO revenue for the month was 23.5%, just under what we had budgeted at 24.7%. In terms of revenue for the month, it came in under budget by $17.6 million. That's a 12.8% negative variance. And it is attributable to lower census and procedure volume in the operating room and cath lab, which drove lower daily hospital service and ancillary service revenues. The outpatient revenue for May was below budget by 6%, and this was due to lower than expected activity in the cath lab and the outpatient lab. In summary, we had 19 fewer admissions and 523 fewer inpatient days than anticipated in the budget. Surgical cases were below budget by 42. Cath lab procedures were below budget by 67. Outpatient visits for May were 18.3% below budget, and ER visits were 2.5% lower than anticipated. Clinic visits for the month were above budget by 0.5%. Total paid FTEs are below budget by 9.4% for the month, and below the last 12 months average by 57.4 FTEs. Inpatient charges for the month were lower than budget by approximately $17.6 million, or 12.8%. Outpatient charges are also lower than budget by approximately $2.7 million. So our total hospital charges for May will come in below the budget by $20.3 million, or 11.1%. On May 31st, there were 155 days cash on hand, down from 157 days in April. The total days revenue and accounts receivable at May was 68.75. The days revenue and accounts receivable excluding Medi-Cal was 67.78. Days in accounts receivable excluding the Alameda Alliance was 61.8. And as we've mentioned before, the Alameda Alliance now has a conservator, and they owe us nearly $50 million. Which I don't think we're going to see. This is the vicissitudes of doing business in this environment. Current outstanding charges from the Alliance are about $50 million. During the month of May, $1,545,194 of charges were approved or pending for charity assistance. The mythology that we shouldn't have any charity because everybody's covered, I think, is clearly illuminated in facts like that.
We have some action items to consider tonight. Dr. Epen will present those. Item A.
Mr. President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase and implementation of the Siemens Clinitech Atlas and interface for the clinical lab department for a total amount not to exceed $128,825. This purchase was included in the fiscal year 2014 capital budget.
Second.
We have a motion and a second. Nancy, if you'd like
It's
to
just
just
very
explain
quickly,
that.
the current urine analysis instrument that the laboratory uses is 11 and a half years old, which as things go, that puts it beyond its useful lifespan. This testing equipment is critical for patient care as well as workflow in the ED. The lab currently performs 24,000 urine analysis tests per year. The current system can only perform routine macroscopic urinalysis. The new Clinitech Atlas will not only do the macroscopic urine analysis, but will evaluate the urine for clinical microscopic cellular components, which is something that we currently do manually.
I think this brings us into the 21st century, in addition to replacing a piece of equipment that we have absolutely used to death.
Christine, if you'd like to take a vote on that.
Sure. Director Stewart?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Aye.
Director Eapen?
Aye.
That motion passes. Dr. Eapen, item B.
Mr. President, in accordance with the Section 9007 of the Patient Protection and Affordable Care Act, I move for the adoption of the Community Health Needs Assessment Implementation Plan, which was developed as a result of the 2013 Community Health Needs Assessment.
Second.
We have a motion and a second.
Yes, I just wanted to mention that Ruth Traylor is here. She did present the Community Needs Assessment to the Board of Directors earlier this year, and if there were any last-minute questions, we'll make her available.
I just think this is a very, very nice thing that is done. It was very informative, very, very interesting to see what came out of that report, and I appreciate Ruth for what she's done on that. But I think we're ready for a vote on that. Christine, if you could.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Aye.
Director Eapen?
Aye.
That motion passes. There being no further business for our open session tonight, we will now adjourn to a closed session. Thank you for your attendance. We reconvene to an open session and announce that no action was taken during the closed session this evening. There being no further business, this meeting is adjourned.